Good morning. Today we have the pleasure to interview Dr. Hussam Saleh, a consultant gastroenterologist, and we're going to speaking about IBD, a very specific condition that a lot of people have lots of questions. But before we get started, good morning, doctor. How are you?
Fine, thank you. And really appreciate your invitation. Thank you very much. It's really an honor and a privilege for me to participate in this kind of conversations and share some of our gastroenterology experience, especially in hot topics like IBD.
Correct. Tell us more about you, because you're not just a consultant gastroenterologist. You do a lot more for the world. So tell us who you are.
Well, I'm a consultant gastroenterologist and hepatologist, adjunct clinical professor in Medical University of Sharjah. Our hospital, as a university hospital, we have the doctors and the medical students that we are participating in their teaching system. And also I mainly a hepatobiliary gastroenterologist, so this is my focus of scope of work. However, the inflammatory bowel disease is a huge subject that we are going to discuss.
Correct.
Yeah.
Okay, so let's dive into it. So let's talk about IBD, because a lot of people don't understand yet what it is, and they confuse with other conditions like IBS or another GI disorder. So tell us more in a very simple terms for people who are outside the medical field.
Yeah.
What is IBD?
We examine a patient and we have to break the news to him in a simple terms. We tell him that this is a chronic progressive disease, so which means that it stays with him for a long time and it's going to progress, and it's mainly autoimmune disease, so it's not his problem that he did something wrong with his habits that caused this problem. No, it's an autoimmune disease that progressed by time, and it's affecting the gastroenterology tract. Beside this, the extraintestinal tract, so it can affect the liver, the kidney, the skin, even the joints and the eyes. So there are lots of things to say about that, but we will focus in simple terms of inflammatory bowel disease that we are abbreviating as IBD. And it can be sub-classified to multiple types, but the main ones are the Crohn's disease or ulcerative colitis.
Okay, okay, perfect. So now, since this is autoimmune, like you say, it's not necessarily that the patient did something wrong, it's just something maybe genetically that happens. How these patients present themselves? What will be the first symptoms that will guide you to like, okay, maybe this could be a presence of IBD? How these patients come to you?
That's a very good question, because we always getting the patients late after 6 months to 1 year from their symptoms. Mainly the symptoms are usually abdominal pain, cramps, bloating, and after that they might have stool habit changes, whether it is constipation or diarrhea, most of it diarrhea. And if diarrhea, it comes to profuse diarrhea, more than 6-7 times a day, it can have mucus or blood in it. So this is when the patient started to get worried, alarm symptoms, and seeking physical or physicians for their help. Most of the physicians, if they are not a specialist in the field, they will start looking in infections or something temporary things. So they can give antibiotics, they can do simple investigations of cultures for the stool and blood test. And when the patient's complaints, symptoms and signs persist, and then they will start asking the specialist in gastroenterology to take it from there.
Okay, perfect. And this is kind of my ignorance, I guess. Is there any specific test that you can do, maybe blood test or anything like that, that can help you fast track the diagnosis of IBD?
Yeah, definitely. So if we ruled out any kind of simple conditions like infection, or we so-called irritable bowel syndrome, which is IBS.
Correct.
This is a totally different entity when there is no any organic condition. So it's a simple exclusion criteria disease. When there is only functional problems, this is, we call it stress-related irritable bowel syndrome, which is IBS. Now let's talk about the inflammatory bowel disease, which is the IBD. That's mean there is organic condition hurting the patient in the whole digestive system. When we talk about Crohn's disease, it's from mouth to anus. I'm sorry to say that, but this is usually what the expression is. The ulcerative colitis is confined to the colon.
Yeah.
So this is the differences between these two.
Okay.
And each one of them has its own kind of symptoms and signs that the clinical picture of patient comes to you to your clinic and explain to you. Our job is to start asking medical history, if there is anything like this in the family, and then we usually ask some lab tests for inflammatory markers, anemia, iron, if it is fish protein, and then the stool test can tell us lots of things, whether there is inflammatory markers called calprotectin, or there is blood in the stool. So lots of signs that can show us that we have to take it from there to do endoscopies, to have a look inside the bowel system and obtain biopsies if necessary to confirm the diagnosis.
Okay, perfect. Doctor, and since this is an ongoing, I mean, once the person is diagnosed, I'm assuming there's no cure because it's an autoimmune, right? So how do you manage this long-term condition so the patient can live a normal life per se? How is the management of this IBD condition?
Yeah, so it's a sensitive and complex situation when you started, as I said, breaking the news to the patient and start to explain to him that this is an autoimmune disease which stays and it can be progressive. So we have to have a good patient-doctor relationship.
Okay.
From there, the patient has to know that the trust we build, the cooperation that we have together, and the patient that we have to be strong so we can move on. Because some patients, of course, I understand they can go for second, third opinions, and they will end up, they understand that I said the right thing.
Yeah.
So the trust is very important to build between patient and doctor. Understand that what I'm saying is on benefit, and we have to do the right things. We confirm the diagnosis by pictures, by histopathology, blood test, stool test, images. This is all including in the diagnostical investigations. When it comes to confirmation, then we take it for the next level of pre-treatment plans or treatment plans.
Okay.
Treatment plans can be conservative treatment, can be a biological treatment, can be surgical treatment.
Oh, so there's definitely many ways to treat this, and we're going to get into that as well. Actually, let's get into it right now, and then I move into the next question. But I know biosimilars.
Yeah.
Something quite new per se in the market, or at least new to a lot of people who didn't know about them.
Right.
How is biosimilars changing the treatment of IBD, and how that you think the patients may be getting a better response to this new technology?
So I feel like I'm old enough to talk about myself and the experience, because I'm lucky to start this field in 1999 when we started in UK, and there we started to have the way of treatment with immunosuppressants. It's called immunosuppressant, which is oral treatment, very simple. It can be also cortisone or steroids to subside the inflammation of the patient.
But they have long-term side effects, right? So I guess that's why similars come into play, yes.
After this, we were always liaised with the big companies to have the research going on about the so-called biological therapies. In 2001, the first one was there, it's infliximab, and then after that in 2005 we had the adalimumab, which is biological therapies that change the way of thinking of how to treat patients. And it's only injections, and it goes miracles. So it helps to subside the immune system, not to respond in an aggressive way to attack the digestive system, which was amazing idea. After that, the progress of the biological therapy went very fast. There are lots of other companies that started to jump inside this business.
Correct.
To develop this, and we are happy to have competitions, because the more we have armamentariums, we call it weapons, in our hand to fight the disease, the more we can be confident to help patients.
Correct.
So that was the equation that we have. By years, by time, things started to take another shape, that the biosimilars, which is the same kind of molecule of these biological therapies, changed to biosimilars, which is having the same safety,
correct,
efficacy, and quality of medicine.
Yes. Yeah, and a lot of less side effects, so that's very important as well. So probably tell us, doctors, because I know when we talk to the patients, they don't understand biosimilars quite yet. It's quite new for most people and into the medical field. So tell us how about their safety. Tell us how safe they are, because the patients truly.
That's why I smile to your portrait, because I will tell you a very nice joke. When we were in UK, I post-graduated in Cardiff, Wales. That I had a very good time there during this period of time for IBD. And one of our consultants and seniors there, he was telling me, Dr. Hussam, in this morning meeting, we need to talk about the biosimilars. So please, the way that you declare it to your patients, don't say cheaper version of the biological therapies, because the patients will feel like he's cheap. No, say less cost.
Yeah.
And I liked it. So look, it's more than 20 years now. I remember this, how the definition of biosimilars, that it is less cost. Don't say to the patients or to the medical team it's cheaper.
Correct.
So it's a very simple terms that can change
the
way
perception. Yeah.
And the way we looked at it, that the medicines, when it comes, it's biological therapies are very expensive.
Correct.
And not all patients have access to this kind of medicines, especially different parts of the world. Europe is well organized by a system of National Health Service, whether it's in the UK or in European Union. However, different places, different systems. Sometimes you can have coverage of the government to their nationals, or other places that they have a system of insurance companies.
Correct.
Like in America or other parts of the world. Now, having said that, not all the patients have access to this kind of good medicines, and if we have less cost with good safety and efficacy, then we will be happy and more than happy to give it to our patients.
Yeah, very good. And there's a specific biosimilar, I guess, maybe you named them already, ustekinumab. Did I say it correctly?
Yes.
Okay, so do you think this is an important option in an IBD management?
Definitely.
Yeah.
To be honest with you, we were really happy when we had this medicine in our hand, ustekinumab. It was developed by Johnson & Johnson company, as an American company, and it turned the way of the game. So I call it the mother of knowledge for the biological therapies. I personally advisory consultant to this company, and I'm really happy that I went through lots of information when it started in 2015-16 to give it to the patients themselves. And I had huge experience about ustekinumab to the patients. So we started with Crohn's disease, then we gave it to ulcerative colitis. Both patients were immediately have a very early good response to this kind of. When we induce the remission and we keep maintaining the remission, it was amazing medicine. We know how to manipulate it, and it's a simple term in definition. It's blocking something receptor called interleukins.
Okay.
And the interleukins is very effective receptors to initiate the immune response, to attack the gastroenterology. Because the ustekinumab can be used to other conditions like skin, like joints, other conditions. However, we use it in gastroenterology for the IBD, inflammatory bowel disease, and we find from the first dose that the patients are responding.
Okay, so is that quick?
They're very quick.
Oh, that's good.
Yeah.
Okay.
So I'm really happy that I went through the ustekinumab experience, and when they informed us that there is a biosimilars of ustekinumab, we were really happy that now more and more patients can have access to this kind of treatment.
And it's available here in the UAE, correct?
Yeah, definitely.
Okay, so we're blessed that way. Doctor, going back, and because I know you have a lot of international experience, which is great. So tell me if this IBD is something that you have seen maybe more common in younger patients now, or is it more common in the UAE? Is there anything that would tell you that IBD is shaping in a way that, how patients are developing more quicker, younger? Tell me, since you've seen some patients in all around the world.
Yeah. So I practice in Europe, most of Europe, like we went through Hungary, Budapest, Austria, and Vienna, in Germany and Amsterdam. All these places have been practicing medicine, and of course in UK as well. And when I came to the Middle East, I thought that the disease is disease, just nothing will happen or change the way that the patient looks. However, in the Middle East, I can say that the intensity of the disease is different, the clinical picture is different. It's less aggressive in the Middle East, at least from my point of view.
That's good to know.
So in the Middle East and Far East Asia, the situation is different, and this is being documented in lots of publications before. Is it because of the westernization industry kind of diet, whether the food habits, we don't know. IBD itself, the cause is sporadic. It's multiple factors. It can be from immune system, from genetics, from the way of patients took medicines of, let's say, non-steroidal anti-inflammatory medications, or abused or misused the drugs of, let's say, antibiotics. Lots of things
factors
are playing there, and we still don't know exactly what triggered the disease. However, in my practices, this is my personal opinion, that my patients in UK, especially the Crohn's disease, I saw aggressive fistulas all over. The fistula is abnormal opening in the anterior wall of the, between the intestines, between the colon intestines, between the skin and the perianal areas. Very aggressive. And nothing is working with these patients until the biological treatment came, and the way that we look into it. And the medicine is going on, the development is going on. We have now the stem cells coming up, the treatment of stem cells. We have even the biological therapies coming from injection to oral treatment as well. So there are lots of bases that we are taking, and we are happy that everything is going through around us about this. But back to your question, I think that here in UAE and Middle East, the disease itself is less aggressive.
Less aggressive,
And most of my patients are manageable. So biological therapy is sometimes more than enough, and it can be monotherapy. So I start with secukinumab with one patient. If ulcerative colitis, he can stop the mesalazines, we call it, it's an oral treatment. Or if Crohn's disease, they can stop the immunosuppressant medicines, like we call it Imuran, after a while. So after the third injection, 5th injection. So the secukinumab itself as a medicine changed the way that we look for management of patients. And from there, the secukinumab gave a hint to lots of companies how to use the interleukin blockers as biological to develop their own medicines. That's why I said the mother of them. Exactly.
And I think you answered my next question, because I was going to ask you how the biosimilars has shaped or will shape the treatment of IBD here in the UAE, but you say that it continues to evolve and it continues to get better each year.
Definitely. The good news about the biosimilars is that, if you want to hear it from me, that the system of healthcare in UAE with the insurance companies, they are accepting the biosimilars as a way of less cost and the way that we can give it to patients. So they always ask us in the system, when we ask secukinumab or other interleukin blockers, that did you try the biosimilars before? Why don't you, sir, go to biosimilars first?
Perfect. So just to complete the conversation, doctor, we can say, I guess, that IBD here is very manageable. We have experts like you. Now we have the great medicine like biosimilars that will help us with. But before we go, tell us maybe the most simple symptoms that someone presents, because like you say, early detection is important. So what would you suggest to someone that, is having some kind of symptoms and they're doubting? What would be those symptoms that you say you definitely cannot ignore?
Definitely. So that's a very good question, because it comes from the patient first, because the patient sometimes anywhere in the world, he might say that I ate something wrong, that's why my tummy is not behaving good, or there is cramps, or if the patient started to feel the so-called alarm symptoms.
Okay.
The alarm symptoms are very simple to remember. weight loss.
Weight loss,
It's very
okay.
important that he's having weight loss despite he's eating okay.
Okay.
The persisting abdominal pain that more than 1-2 weeks, that is still persisting and it's not
Going away. Yeah, okay.
Yeah. If the stool habit changes, started more than 3 days, it's not changing, and it started to be profuse diarrhea
Okay.
with mucus and blood. So the blood is a very, very red line alarm symptoms.
Correct.
And of course, the fever. If it is also, there is fever in between, the patient intermittently feels like there is a fever. He's not feeling better with temperature. And of course, other things like vomiting. But this is the main alarm symptoms.
Yeah.
I told you that this
Main
is,
alarm
yeah,
symptoms.
this
Okay.
is a line that he should not cross. He should stop seeking physical care. And of course, he can go whoever can be in his hands. He doesn't have to reach us immediately, because there is a kind of basic investigations that should be done, blood test, stool test. And of course, they can give them antibiotics or whatever supportive medicines. And after this, if it doesn't go away, then they have to come back to us.
Okay, perfect. So if they have this 5 alarming system, make sure you seek medical expertise.
Definitely.
And just to give the patients or future patients a good peace of mind,
Definitely.
is there's good treatment for IBD, is very manageable, and we have a specialist like
We are
you
always here to help.
with all the technology. Okay,
Definitely.
perfect.
Thank you.
Doctor, it's been a pleasure. Thank you so much for teaching us about IBD and how we can manage it and everything that we can do about it. So thank you, Doctor.
Maria, the pleasure is all mine. And I'm so happy that we said it as big part of it. There are lots of details to say,
Correct.
but at the end of the day, the message, I think it's delivered. And it was really nice to have a good time with you.
Yeah, thank you, Doctor. Thank you.
Thank you for having me.
Perfect.